Healthcare's digital front door is jammed. Before patients ever see a clinician, they have to wrestle with insurance verification, which is a slow and confusing process that can delay care. But what if eligibility and benefits could be verified instantly, in real time? Welcome to CareTalk Executive Features, a series where we spotlight innovative companies and leaders working to advance the healthcare field. I'm David Williams, president of Health Business Group. My guest today is Dr. Ashish Mandavia, CEO and co-founder of Sohar Health, which is using AI and automation to make the front end of the revenue cycle as seamless as the rest of digital health. Ashish, welcome to CareTalk.
Thank you for having me, David.
Well, I have to ask, how did your background as a psychiatrist shape your view of administrative barriers to care delivery?
Yeah, it's a bit of a journey. So I appreciate the question. It's often the first one that I get asked. As a psychiatrist in the European healthcare system, I think I'd say I very much saw firsthand the power of kind of simple, transparent access to care. No surprises, no barriers. If a patient needed to come in to get some support, they could. Coming to the US, I was very much struck by how administrative complexity can kind of delay care, frustrate patients and providers. Hearing peers and colleagues talk about endless hours, maybe in the ER setting or urgent care setting, kind of having to be on phone to an insurer to kind of ensure that they can give good quality care to their patients, the care that their patients deserve. It gave me a sense of real kind of shock, firstly. But then when you get over that, it kind of seems like, okay, this is not so much a clinical issue. This is more of an infrastructure issue. And so I've seen clinicians burn out, patients turned away, all because navigating insurance complexity is a bit of a maze. And I think those experiences of being able to empathize with patients who are really trying to get the care that they need and are desperate for that, and providers who are ultimately wanting to do what they were trained to do, which is deliver good quality care, has shaped my belief about trying to fix these kind of invisible bottlenecks that exist to help improve access and trust in care.
Well, welcome to America. It's a rude awakening. I have family from Canada, and that's even though it's just across the border, sort of equally shocking. Meanwhile, we throw cast aspersions on those healthcare systems. All right. So when you started to discover that, there's a lot of different inefficiencies and a lot of administrative ones that we have in American healthcare. So why the focus on eligibility and benefits verification specifically?
Yeah, that's a good question. It seemed like a very natural place to start. If you were to think about revenue cycle management as a spectrum or a kind of cycle split between front end, mid, and back end, where my co-founder Lucas and I were at a company called Pelago. They used to be known as Quick Genius. I think you may have spoken to their CEO just a few weeks ago. We kind of saw firsthand as we kind of made the move over from Europe to the US of how you could go and get credentialed with or contracted in with an insurer. But then when you kind of come across the hurdle of having to handle RCM, you would endlessly get wrong data, have to be on the phone to payers, and ultimately get a lot of delays to your cash flow. And so we realized that if you don't get eligibility and verification of benefits, network status determination right at the front end, you're really setting yourself up for denials later on. And so it's that invisible pain point that affects every provider, but hasn't really got a more kind of modern, slick digital health, I guess, approach towards it. And thus, it's easy to get wrong, and people have kind of lost faith in the credibility of the data that they try and get back in that sort of space. I think also the patients themselves kind of are a little bit wary of the messaging or information that they get, which often leads to them either not trying to access care further or just moving on to another provider organization who's a bit more confident with whether or not they're going to be seen and their insurer is going to pay for their care or not.
Got it. So you mentioned RCM. So for those that aren't, living and breathing RCM, which unfortunately does not stand for Radio City Music Hall or something like that, but revenue cycle management, what's broken in insurance verification today? I mean, I think about it sort of very simplistically as I have my card and somebody wants to know, if I have insurance, I can just verify it by showing them my card or the digital equivalent. So what's broken?
Yeah, I mean, it's mainly broken because the data itself is fragmented. It's located in many different places, and there's a lot of misalignment of incentives. So payers hold that data ultimately, and providers are chasing it. And so the systems that connect between both the providers and the payers were built decades ago. I mean, it really was the evolution or the natural step from moving away from paper faxing was to do kind of archaic data transfer, which is sort of like digital faxing, and that means that you get data points that are kind of inconsistent, incomplete, which ultimately mean that you get inaccurate data being pulled back from the payers. And AI is finally kind of giving us a way to clean up, validate, and interpret that data in real time, which is something that kind of the legacy sort of technologies that sit between the two kind of sides of the coin, the providers and the payers, really kind of struggle with. So ultimately, I think it really does come down to that misalignment of incentives. Ultimately, insurers are underwriting risk. They're not so much technology companies. It's not their number one priority to surface this sort of data in a timely, fashionable way. And providers want to try and get patients through the door. So they want it delivered in a fast way. And it's frustrating to them when they have to go onto a portal for an insurer or pick up a phone call and call the insurer. So I think that's certainly where the kind of biggest challenges lie. And like I think I alluded to earlier, if you don't get it right at the beginning, it's very difficult to correct later down the line. So it's all well and good getting to delivering care, giving a great patient experience there, and then submitting the claim. But if the payer comes back and turns around and says, well, actually, you weren't in network with that patient's plan, then there's not really too much that provider can do. They can either write off that claim, they could go back to the payer and try and argue their case, or ultimately, and all too often what happens is that they end up landing the patient with a surprise bill. And that's not a great experience. Ultimately, the patient may end up in debt, or if they can pay off their medical bills, then they're probably going to be a lot more wary and mistrusting the next time they come along to try and access care. And that's a vicious cycle that affects the patients at the core.
So it sounds like, the incentives are out of alignment, which is fairly typical. I think there's also, you may be alluding to some technology issues because these payers are, these are big kind of insurance companies, and they literally use mainframe computers with some of these databases, which are just not designed for someone shows up online and instantly wants an appointment. So I think that, you're probably leveraging things like APIs and AI in order to actually go from it and make it look like, hey, these systems were actually set up for this kind of use. And differently, I think, from a legacy clearinghouse system. So what's the Sohar approach compared with, how others have tried to tackle this problem?
Yeah. So our approach has always been to take an API first approach. And for anyone listening who's not entirely sure what that means, it's a form of interface or exchange of data that is particularly robust. It's quite simple to integrate, but it means that a lot of various different transactions can be happening during that API call being made. And then once an organization or a technology platform like Sohar has got that information from the insurers, then it can be called upon in order to then surface up to the patient. And a key component to that is actually, can we do that in a time frame that makes sense as a patient is going through an intake flow? As you alluded to there, coming onto a website and actually trying to access care there and then. Patients now are so used to, in a kind of retail environment, choosing the items that they want to add to their cart, then getting to the checkout and instantaneously being able to make a payment. It's so different than that in healthcare. There's endless questions to go through, endless information to give, and then typically you're met with a screen at the end of it to say, okay, we'll get back to you in 24 hours or in 48 hours to let you know if we can take this on board. So what Sohar really aims to do is do a lot of that kind of those processes very quickly under the hood, and then surface that up for the provider to then display to their patient. It's very much trying to be that invisible infrastructure layer that sits between the provider, the clearinghouses, and the the payers. And that allows us to really work with many different vendors in the space, not just being beholden to the insurers themselves. So we go where the data is, and we really build a huge amount of robust resilience under the hood there in order to find that data if we can't find it from the kind of regular sources.
Got it. So I love your marketing claim, which is 99% accuracy and verification under 30 seconds. So I love the claim. Yep. Is that actually doable? You described a lot of complexity. Is that an aspiration, or is that you achieving that?
We're achieving that. So when it comes to determining if someone's eligible or not, we're achieving 99%. It's hard work. It's a lot of monitoring and scraping of information, but it's achievable. The harder part is actually making sure that the numbers that come back from the insurer, so the actual benefits information, copay, co-insurance, deductibles, whether that's individual or family deductibles, are as accurate as they possibly can be. And the reason for that is that there's so many different numbers that are surfaced up from the insurer. Like if you're going for a telehealth psychiatry appointment or a psychotherapy appointment, there may be different benefits associated with that, or that would be different from going for a dermatology appointment. And so making sure that you can pull those numbers accurately, that's where the challenge comes in. And that's often where solutions kind of very much fall short. They're really designed to try and just focus on general medical benefits and not so much honing into specialty care or into areas such as ophthalmology or dentistry. So this is kind of the Sohar difference. We do apply a lot of that technology that you're referring to earlier, the use of AI, machine learning, to be able to kind of pick that data out accurately. And when it comes to surfacing benefits, we can accurately determine that we can be between 93 to 95% accurate with surfacing those benefits. On the speed front, well, that's a really interesting one. Our average speed for running one of these checks typically sits at around 7 seconds. So it's not quite Stripe milliseconds, the ultimate kind of consumer-like experience, but it's getting pretty close. And that's way better than 20 minutes on hold with a front end operations team member who has to phone up the payer, or waiting that 48-hour period to hear back from the provider organization while someone in their back office is making the call or compiling all the information and data. So I very much kind of stand by those marketing claims. It's important that we can stand by them, and we validate them in quite unique ways. So we analyze not only the eligibility information for our provider organizations, but we also analyze their claims data. We don't do much with their claims data. We don't submit their claims for them. That's something that they already have figured out and are very efficient at doing. But what the claims data really unlocks for us is telling us whether or not that data we surfaced up during the intake flow matched what was on record and on file with the insurer. And if you complete that feedback loop over and over again for a certain plan, certain payer in a certain setting, then you can get to really high levels of accuracy. And that's exactly the secret sauce that drives Sohar.
Great. Excellent. And you can disclose what it is because it's hard to do. So that makes sense. So I think it's self-evident from the discussion we've already had, but maybe you could make it tangible about how having improvements like this could translate into better outcomes, for providers or for patients. I understand less friction, less burnout, quicker time to care. Can you make it tangible what that might mean for a prototypical patient or in some other way?
Time and time again, what we can see on our side is that a patient will access a provider. And when I say access, I mean they will go onto their website or give them a call and try and book an appointment. And if they can't get a response within 20 to 30 seconds, they're already Googling the next provider organization. And here I'm really referring to the kind of direct to consumer digital health providers that will advertise on television or Facebook or Instagram. And you can really see it happening. They will try with one provider organization. They won't be able to get through, or it's taking them too long. So they'll go to the next one, and then they'll go to the next one. So in terms of tangible difference for the patient, the sooner that they can get a response and an answer, the more likely they are to, one, put their credit card on file or pay upfront for a consultation or a provider visit. And two, they're much more likely to then attend that initial appointment that they book. How does that translate on the other side, like on the provider side? Well, it's very, very tangible. The business case really sits there. So from an operations perspective, it's 1,000 hours of manual work hours per week being saved. It's 90% of your operational costs associated with your front end administrative staff potentially being reduced or redirected into another area of that revenue cycle continuum. It increases conversion. And ultimately, what we are seeing with our customers that we work with, those direct-to-consumer digital-first providers, such as the likes of Talkiatry, Ruler, they are seeing upticks of 20% in patient conversion. And their definition of conversion is, does the patient actually make it and attend that first appointment? That's what matters to them. And so ultimately, what I feel is that we are broadening access. We're creating a much more enjoyable, frictionless sort of patient experience, but ultimately driving top-line revenue generation for provider organizations and making their cash flow worries also a little bit easier. In some cases, we've seen that because of using our network status feature, so determination of network status based on the patient's plan, providers have completely zeroed down any claims denials associated with being out of network. And those are particularly challenging to be able to kind of combat with the insurer.
Well, it's a very good value proposition because you're not just talking about, saving a few cents on a transaction, but if it's done right, it's the difference between having that patient in the first place, and then even if you do accept them, about whether you're actually going to get paid or not. So it's a good position to be in. You mentioned a couple of well-known names. I was going to actually ask you if you can name customers. I love the name Talkiatry, by the way. That's an awesome name. Ruler is good. Any other cool ones you can name, or other ones that bland names?
So the organizations that we work with include Talkiatry, Ruler, BetterHelp, Cerebral, and Two Chairs. I mean, you can see a trend developing there. They're all direct to consumer. They're all typically in the behavioral health space, and that's where we've certainly carved out a bit of a niche. But beyond that, we've started working with larger group practices who deliver kind of care physically. And are basically powering a lot of the tooling that they already have and integrating directly into their practice management software or electronic health record, so that their existing teams who are on the ground picking up the phone or seeing patients come through the door can use this technology to make the experience better for a patient.
Let's talk about why you started in behavioral health. I mean, there's, your clinical background would obviously lead you there, but anything particular about behavioral health as a starting point?
Yeah, it's really hard. As a space goes, a lot of the rules that apply to other medical specialties really don't apply in the case of behavioral health. And on top of that, because the supply of providers within the behavioral health space is very limited, we see a lot of carve-out payers existing or carve-out plans existing, where essentially large provider networks will offer their services to various different insurers, so that then those insurers can say that they do cover behavioral health care. Ultimately, that creates a bit of a spider's web in terms of, if I'm going to go to Blue Cross Blue Shield California to go and see a psychotherapist, then actually we probably need to be checking insurance benefits with a carve-out entity like Carelon or Magellan, because they're likely going to be the provider network who's delivering care. And when you have that sort of level of nuance in there, it becomes very difficult to ensure that benefits are accurate, that network status is accurate. So I think where we really kind of felt we could develop like a stronghold is with going after a space that was very, very complex, but really needed help, and therefore saw high volume of patients coming in, a lot being turned away or churning because of insurance-related challenges, and a lot of claims being denied and therefore written off by those companies. So they could really see the benefit of our technology quite quickly. As we move on, of course, we look to expand into other areas, and when we've done it to this degree and this level of sort of depth in this area of behavioral health, the other ones kind of naturally kind of layer on, and we've built our infrastructure as such that it can kind of move into other specialties. So now we also offer our services to primary care practices, to weight management facilities, particularly hot topic, physical therapy, occupational therapy, and speech and language therapy.
Got it. And are there differences in working in a different care setting, like a physical space or hybrid compared to the fully digital?
Yeah, exactly. And then what you see there is then like a bit of a blurring or change in kind of terminology as to what's eligible and what's not. As soon as you get into physical settings like treatment centers, for example, where someone may be in for a prolonged inpatient stay, the definition of eligible is, okay, yes, does that patient have active insurance and will it cover them for this service? But then it goes all the way into the depths of, do we have prior authorization as well for delivering this care? And that's why our process has lent itself really to the kind of outpatient setting, high volume, high turnover of patients sort of coming through the front door settings. The challenge, I guess, in digital health is that care can happen anywhere. It could be in the patient's home. It could be via telehealth. It could be that hybrid model that you referred to. And those encounters don't fit kind of neatly into that kind of legacy insurer logic, which is that either you're seen in hospital, a care setting of some sort, or an outpatient or office visit. And so that definitely brings in a layer of nuance. The other challenge is that with digital health companies, they have newer CPT codes that they bill on. And those aren't particularly well mapped. So often kind of verification breaks there. So we certainly see there being subtle differences and like kind of wide differences in different parts of the healthcare system. But ultimately, where the most volume of these sorts of checks take place, it really does lend itself to speed and being done quickly and in a timely manner.
Do you have a vision of what a fully transparent digital front door might look like in healthcare?
Absolutely. And that's like one of my favorite questions to answer. Well, imagine you jump onto a website, you go onto an app, or you attend a clinic, and you just simply tell them a bit about yourself, your first name, last name, how old you are, and where you live. And they were immediately able to bring up, okay, here's your insurance information. Does this sound about right? Great. Well, these are all the types of visits or types of care that you would be eligible for, and this is exactly how much it's going to cost you. Would you like to proceed? Yes or no? If yes, you make your transactional payment, and if no, then you look elsewhere. But what's that really sounding like? Well, it's almost sounding identical to a more consumer-like retail experience, right? It's like the Amazonification of healthcare access. And this is something I really strongly believe in, that why should it be so challenging? Why should it be so difficult to be able to work this one out? Because ultimately, both sides, both the patient and the provider, want to be able to kind of come together to be able to deliver care. And this is really a friction point and bottleneck in that process.
I think it's helpful. I mean, the Amazon analogy is a good one. And since everyone has that experience, they kind of know what's possible. So you say, look, I used to have to go out to the store and wait and put something on,
right,
layaway or whatever. And now I have all these other ways to do it. You can't just tell me that healthcare is all going to be, the same. And you have some younger patients that never actually had that type of experience. They're like, what is this? Like, am I visiting, never mind like visiting the US from Europe, but just like, on a different planet. It's not acceptable.
Right, exactly. And I think particularly with some of the customers that we have who particularly focus in on the students delivering care, particularly mental health care for students, whether they're at school level or at college level. Yeah, that's the experience that they want to give their customers. They they know that their customers really have never had to kind of go and look up their insurance information. One of the big challenges actually we see with those customers is that it's very hard to map their addresses, because their address with their insurance on file tends to be back home with their parents. And the address that they quote when they're trying to access care is their college address, or like where they're living at the time. And subtle things like mapping that on to make sure that we can get the right data is really important, and a lot of what we do on the back end within Sohar. So yeah, trying to bring about this new approach towards the digital front door. I mean, it just seems like a natural progression, and also in keeping with movement towards pricing transparency, ending surprise bills, and preventing kind of medical debt. So certainly a place that I really enjoy and am passionate about kind of leaning into, because that's where I really feel like we give value to the actual end user, the customer or the patient.
I mean, I guess if I'm thinking about it from a patient outcome standpoint, and I'm dealing with the population, let's say, of student level behavioral health, even if I was no good as a clinician, if people are coming for anxiety, stress related things, if you could just make it the process of dealing with the counselor less stressful, you're probably going to help cure them that way.
Big time. And just imagine the scenario that you go through the process. Maybe it is seamless, but maybe actually the data that came back was not correct. And in that time period between you accessing, booking your appointment, attending your appointment, a claim being submitted, and a claim denial coming back, you could have actually, in that 3-month period, seen that counselor maybe 6 times. So each of those 6 times, you were potentially out of network. And therefore, you owe the money for each of those 6 sessions. And maybe at the beginning, your expectations were mismanaged to say, you're just going to pay $10 or $30 every time you come in. So suddenly a bill that you thought of around $180 over a 3-month period becomes more like $600 over a 3-month period. And that in itself causes an endless amount of stress for patients. And imagine, and often some of our customers will say, look, I just want someone to be able to tell my patients that we've got them. You're okay from an insurance standpoint. Let's not think about that. Let's focus in on your care. And often a lot of the time that they spend on the phones or having to counsel their customers is around their insurance or the bills that they're receiving, as opposed to the actual care that they want to deliver.
So if I look at the RCM industry, they've certainly have put an emphasis on front-end operations, these issues about wanting to make sure that the provider is going to get paid for a patient they're seeing and so on. I mean, these are standard bread and butter kind of issues. But what is the traditional part of the RCM industry get wrong about front-end operations?
Well, first, they know it's a problem, but they tend to neglect it. They focus so much, and this is really a kind of a slightly top-down challenge, where the CFO or the head of finance within these provider organizations will be looking at the RCM team to kind of tell them, okay, what is our claim denial rate? What are the main causes for our claim denials? How fast are we getting paid for any denials that take place? How successful are we with the appeals process? As you can see, it kind of focuses purely on the back end of the revenue cycle management spectrum. And certainly an on vogue trend at the moment is focusing in a lot around kind of the administrative burden of coding and ascribing and coding of an encounter. And that certainly has a place, and is why the big organizations in this space like Epic are producing features in order to kind of solve for that. But if ultimately the things that were done within the first few minutes of that patient encounter were done incorrectly, it's all well and good coding up really accurately or really fast. It's all well and good submitting that claim quickly, but it's still not going to result in better collections. It's still going to result in delayed cash flow. So I think that where we see kind of 50% of claim denials being associated with front-end RCM errors, I think ultimately RCM teams are really struggle to be able to do anything about it. often front end front end revenue cycle management sits with the operations team within a provider organization, or if they're a digital health company with a product and engineering team, that typically sits with marketing and a product team. People who don't really know what revenue cycle management is, or don't really understand the importance of getting these numbers to be as accurate as they possibly can be. So I think that the kind of fractured nature or fragmented nature of the various different functions in the organization mean that people know that front end RCM is a challenge, but don't know how to solve it. And secondly, I think that a big part of it is that a lot of the emphasis goes on to how much money are we making, and then it gets forgotten about, okay, how do we go about trying to improve things over time to stop the revenue leakage later on, or improve our cash flow. And then my final view and thought on it is that yes, front end revenue cycle management is important, but it tends to be something that's done in bulk. It's legacy systems that move in batches. It doesn't move in real time. And that's exactly like the space where our technology kind of bridges the gap, moving these processes that you would expect to happen ticking over overnight if you're working on an active patient roster in a large healthcare system, and like bringing that into real time. And that's where the change really needs to take place.
We talked about your use of automation and AI upfront to do this, less than 30 seconds, I guess, 7 seconds on average time frame. If we broaden it a little bit and ask, how can automation and AI reduce denials and improve financial transparency? Maybe you can expand on what you've already described.
Yeah, well, absolutely. In terms of where automation and AI in revenue cycle management can improve denials, well, it's all across the RCM spectrum, and really with varying degrees of kind of impact. But overall, it's a positive thing for revenue cycle management, because so many of the processes are manual, so many of the processes are repeatable, and therefore so many of the processes are scalable through using AI. So we've already alluded to AI coding or AI scribing, and then AI coding up of an encounter. Then you've got tooling out there that allows you to submit claims really quickly, monitor those claims, predict denials from certain payers that often deny claims associated with that sort of encounter, for that specific rendering provider, and are able to kind of preemptively prepare the appeal ready for it. In our space, where AI really helps us is by completing that feedback loop between claims data and the information that we're getting back from the insurers. So the more data that we receive back, the more claims data that we review and analyze, the more accurate we can make the kind of assessment or the discovery process in the intake. And that can get very personalized and granular down to that customer level, which is fantastic. But also, every customer benefits from the economies of scale and the learning from all the others. So over time, we can really crank up that accuracy rate from, say, 75% as a baseline up to 95% in those claims that I was kind of talking about earlier. The other kind of like unlock that we've seen, particularly over the last 12 months, is the use of large language models. So where you have these really large, and when I say large, you're scrolling and scrolling and scrolling through this machine readable data that gets sent back to us by the insurers and holds all the information in it. The information is there. Being able to pick it out in a consistent and repeatable way has often been a machine learning problem, and certainly is the foundation and core of what Sohar does. But for that added refinement, especially as every now and then the insurer will say, actually, you know what, we don't want to take deductible into account if it's a telehealth consultation, or we do, then adding on a layer of LLMs really, really helps us to fine tune the accuracy there. And again, using large amounts of data to be able to train those LLMs and keep them on good guardrails means that we can get very accurate, consistent results.
So we've been talking a lot about speed and accuracy, and now I want to talk a little bit about simplicity and clarity. And I'd like to discuss it. I'd like to hear your thoughts about it in the context of benefits. When I look at my benefits book, because it's literally a book, and say, is this covered? Is that covered? It's very difficult to understand that. So how do you think about simplicity and clarity and their role in engendering trust, and also offering access?
You're not alone. I think a lot of folks over in the US really struggle to interpret what their benefits are, what they're specifically covered for. I think I read a remarkable statistic when we first embarked on this journey that only 4% of Americans know the definition for copay, coinsurance, and deductible. It doesn't surprise me. It's taken me ages to figure out exactly what those things mean and how they interact with one another. And I've been in it, like deeply in it, for such a long time. So a big part of this is trying to simplify and decant those huge summary of benefits that you get. And by the way, aren't there so many of them? I mean, I come from a system where in the private medical space here in the UK, there's only 4 insurers and about a dozen plans each. In the US, you've got 1,000 insurers and you've got unlimited number of plans underneath each insurer who could have different types of benefits for different types of services. The computations really make the mind boggle, which means that I'm not surprised that patients find it really difficult to struggle this, and so too do the providers. So for us, simplicity and transparency is really at the core. We take all of that information, those 30-page long sort of documentations, and we decant them down to the very specific information that's needed at the time and point of care. And in doing so, as long as folks trust the numbers that we're surfacing up, we just make people's lives easier. Then they don't have to think about all the other things that are included in that pack. They don't have to determine, am I going for this type of behavioral care visit or am I going for this one? And why is it slightly different between those? That's exactly where kind of Sohar looks to kind of bridge the gap. The layer needed on top of that, and that's not something that we offer. Actually, we try and educate our provider organizations to deliver this to their customers and to provide that ultimate kind of patient experience is to explain the numbers that they're looking at, where that good faith estimate has come from, what those numbers actually mean, and really like put their money where their mouth is, so to speak. Put that. So if we're saying to you that you're only going to have to pay $30 for this consultation, and they're comfortable with the numbers that they've surfaced up there, then they should stand by that, and they shouldn't then come around later down the line to then collect more money. And we see often providers in that kind of paradox. Should we go back to get more money from our patients when we've said one thing and the payers have said another? Or should we just, even in the case of where a patient may have overpaid initially, should we refund them that difference? These are often kind of decision points that provider organizations are making, and ultimately result in a good or not so good patient experience.
Well, I don't know if the podcast hosts in healthcare would score any better on the copay, coinsurance, and deductible, but I'll say even if only 4% can define it, 94% don't like it. So it's better to have a good understanding of it. Well, that's it for another episode of CareTalk Executive Features. My guest today has been Dr. Ashish Mandavia. He's CEO and co-founder of Sohar Health. We've been discussing how to transform the front end of the digital health revenue cycle. I'm David Williams, president of Health Business Group. If you like what you heard, please subscribe on your favorite podcast platform. Ash, thanks so much for joining me today.
Thanks for having me, David.